Pharmacogenetics and pharmacogenomics both study the relationship between genetics and drug response. While the two terms are often used interchangeably, pharmacogenetics usually focuses on single gene variants, whereas pharmacogenomics looks at the broader spectrum of multiple genes working together to influence drug effects. Pharmacogenetics is defined as the study of the genetic basis for differences in how patients respond to drugs. Pharmacogenomics expands this concept to the entire genome, considering many interacting genetic factors. Together, they form the foundation for personalized medicine. Pharmacokinetics describes what the body does to a drug, how it absorbs, distributes, metabolizes, and excretes it. Pharmacodynamics explains what the drug does to the body, its mechanism of action and effects. Genetic differences can influence both pharmacokinetic and pharmacodynamic processes, altering how effective or toxic a drug may be for an individual. Genetic variants can profoundly impact drug response. By understanding a patient's genetic makeup, clinicians can better personalize treatment, reduce the risk of adverse drug reactions, and improve therapeutic outcomes. This approach paves the way towards safer and more effective healthcare. Let's discuss genetic polymorphisms that influence drug response. These genetic variations play an important role in how patients metabolize or respond to medications, and understanding them is key for personalized medicine. The first group involves the cytochrome P450 enzymes. These include CYP2D6, CYP2C9, CYP3A4, and several others. These enzymes are some of the most common sources of variability in drug metabolism. Variants in these genes can significantly change how a person processes drugs like warfarin, codeine, and certain anticonvulsants. The next group includes enzymes like TPMT, or thiopurine methyltransferase, which affects how patients respond to 6-mercaptopurine, a drug used in acute lymphoblastic leukemia. UGT1A1, or uridine diphosphoglucuronosyltransferase, affects irinotecan therapy, commonly used in colon cancer. And DPYD, dihydropyrimidine dehydrogenase, impacts response to 5-fluorouracil chemotherapy. Some polymorphisms affect proteins that transport drugs. For example, SLCO1B1 influences hepatic uptake and directly impacts simvastatin therapy. Another transporter gene, ABCB1, encodes for P-glycoprotein. Variants here can alter the effectiveness of drugs like chemotherapeutics and digoxin. There are also variations in the drug targets themselves. For example, HER2 overexpression in breast cancer determines whether trastuzumab, also called Herceptin, will be effective. The VKORC1 gene affects warfarin sensitivity. Variants in calcium-potassium channel genes such as KCNMB1 influence how patients respond to drugs like verapamil. And finally, changes in G protein signaling, like the G-beta-3-825TT variant, are linked to differences in response to tricyclic antidepressants and serotonin reuptake inhibitors. Lastly, some genetic markers are linked to disease and drug safety. The HLA-B5701 allele predicts hypersensitivity to abacavir, used in HIV therapy. Meanwhile, HLA-B1502 is strongly associated with severe reactions to carbamazepine and phenytoin. In summary, pharmacogenomics gives us insight into why some patients respond well to therapy, while others may not respond or may even experience harmful side effects. By testing for these genetic polymorphisms, clinicians can tailor treatment for safer and more effective care.